certainly the best technique for decompression. I'm last speaker, so please listen carefully that after the vote, you know what, after my presentation, you won't know what to vote for. I have to tell you that I have a consultant contract with Storz Company, and I hold some patents together with them, which is unrelated at least to my stay here. I have described to you where I'm from. I will skip this. Now we come for the endoscopic technique. Endoscopy in spine is a very difficult topic, so I cannot go too much into detail in this short 10 minutes. But you have to have in mind that in contrast to other endoscopic applications, you have no preformed cavity. And I think this is a major point when we discuss endoscopy in spine. And you have to create your workspace to use the endoscope. So you need to gain some space, and at the end, this created space should be as small as possible. However, you have to gain sufficient decompression. So it's a very difficult condition when you apply the endoscope in degenerative spine disease. What is the indication for surgery in lumbar canal stenosis? When you look at the papers and at the guidelines, at least in Germany, I'm pretty aware of most of the guidelines in the orthopedic societies. Always conservative treatment is recommended, which I think, if it's a clear claudication, is absolutely useless. But these are the guidelines, so we try to do some conservative treatment for some weeks. This is also to gain some interaction with a patient, to gain a relationship, and then to establish a trusty relationship. One, the indication is a typical lateral recess or central canal stenosis, and if you have instability in the lumbar spine, you have to exclude this. Then I think the endoscopic approach is not very helpful. We have done very few endoscopic decompression followed by percutaneous fusion, but I think most of the time when you combine a sufficient decompression with fusion, probably you don't need the endoscope. Surgical technique is absolutely basically the same as you do in the standard technique. The only difference is that you need much more calculation and much more precision when you start the procedure and during the procedure than you need with a microscope or any open decompression. So calculation with a lateral X-ray is very important. Then you go step by step with the dilators and introduce the worksheet. You control again with the X-ray, and then you decompress step by step. The intraoperative view is usually very, very good when you use HD scopes. And this is an example of a discectomy, but this is exactly the same with a decompression. You can do this with a 1 centimeter skin incision. And this is the example of a case with a lumbar canal stenosis decompression. This is a unilateral approach, so pretty much what Dr. Koch just told us, but you see the magnification. It's a much more focused approach. You go right medial to the facet joint, and then you go step by step. The difference is that you really have to start in the midline, because in the midline, even if you have very severe central canal stenosis, in the midline there's always some remnant space. So you have to start in the midline. Since you go not like usual from the decompressed part to the compressed part, you start in the area of maximum compression right away. So you have to start from the midline and then go lateral. And this is the magnification. Just the suction tube is about 2 millimeter diameter. The Harrison punch is a 2 millimeter punch. And you see this is already the contralateral side, the contralateral decompression. You see that you can do contralateral decompression step by step. This is with this endoscopic view until you really have visualized the nerve root on the contralateral side and seen the shoulder and the axilla, and even can see the neuroforamen and decompress everything step by step. So actually, from my perspective, this is even easier than using a microscope. And I completely disagree with the statement of the first speaker, or the second, I don't know. In an obese patient, this is an ideal indication for endoscopy. It's not, I don't say that it's easy, but it's ideal indication, since you even don't need these very huge approaches, very huge exposure, large wound area. You can use just a percutaneous technique for this decompression on the lumbar canal stenosis. Okay, now this is now ipsilateral decompression. I think you all see the basic technique. And this is a example of a post-op image, so you can nicely decompress both sides under preservation of the facet joints. This is a small series where we have just evaluated lateral recess stenosis, so it's not central canal stenosis, it's just a small series of lateral recess stenosis without instability, where we did pure treatment with the endoscopic system. This is the second generation EasyGo system, so this is a series started in 2015. You see that total so far is 30 patients. All operations were unilateral. I think this is a very good indication for an endoscopic approach. If you need bilateral, the larger the procedure is and the more wider the decompression area is, the less significant probably is the limitation of the approach, the reduction of the trauma, the effect of the endoscopic technique. You see, this is the surgical time. It's about 1 hour. And this is the size of the trocar we used. And this is the post-op hospital stay. Post-op hospital stay is a very difficult matter to evaluate. This is very different from, for example, the States to Germany, when we have a lot of American people, because Landstuhl military hospital, American military hospital, and the Ramstein airport, military airport from the States, it's just 30 kilometers away, so we are the major referral hospital. So all the Americans, they leave right away. It's very different. It's very different culture. So if a German stays 1 week, an American usually stays 2 days in our hospital. So this is a difficult point to evaluate, but when more likely it's when you look at paresis, post-op paresis, you see that a lot of paresis either had no paresis or the paresis was resolving over the follow-up period to remain unchanged. You see the pre-op to post-op pain. You see that most of them, 2/3, had immediate pain relief of this typical claudication, and about 1/3 had declining pain and but did quite well. And sensory deficits, you see here, it's also, and some of them declining, some of them had even no permanent sensory deficits. When we look at this series, we have quite good results for the post-op pain. We have good results for the motor weakness. We had 3 cases of CSF leak, which all could be treated without conversion to open. There were no root injuries, no new deficits. There were no post-operative wound infection, which I think is another big advantage using these tube systems, because you basically have no wound infection. Since you never touch the skin, it's very unlikely that you bring in any bacteria. And we had in one case to switch from a smaller to a larger trocar. So the endoscopic technique provides accurate, reliable, and good conditions for endoscopic surgery. And this technique is very safe. And if you're familiar with this, I think you can do the sufficient decompression with minimal muscle trauma and superior cosmetic results. And thank you again for listening. And if you want to, you can come for the ISMISS meeting in September. Thank you very much.
Okay. Questions for any of the authors?
I would like to ask your opinion about the underwater endoscopic systems and the tubular-like systems like you used, the difference and advantages and disadvantages.
Okay, that's a very important question. So you think underwater, like transforaminal techniques, or or interlaminar techniques with the okay. Well, the thing is, for lumbar canal stenosis, in my opinion, at least for these patients I described here, we do this endoscopic approach. There's no way to do this with a percutaneous system underwater. So like spine tip, like the joint marks, whatever. Because you have a large area you have to decompress. You really need sufficient decompression. And I don't know, but transforaminal decompression of a lateral recess stenosis, maybe I do it wrong. I was not able to do so. I think the percutaneous transforaminal techniques are very nice for disc prolapses, even medium disc prolapse. Lateral, I think there's no question, but for bony stenosis, we don't use it. I don't think it's a big difference if you come from posterior or you come transforaminal. I don't see the advantage, and I think it's much easier to get a sufficient decompression when you do the standard interforaminal approach.
Other questions?